morning and thank you very much for the invitation. I would like to start with saying that Dr. Shaina Daud's talk was outstanding and very enlightening. Um, Dr. Biswajit is here.
No, ma'am, he couldn't.
Okay. We have already got knowledge of the esteemed panelists, Dr. Prasad, Dr. Shekhar Patil, Dr. Preetham, and Dr. Gautam. I would move on to my slides. Uh, I would like to start with a disclaimer that all my cases are arbitrary and this is just meant to discuss the points of relevance. First, with a case of a 57-year-old male who presented with complaints of abdominal pain and irregular bowel habits. The CT scan showed a short segment circumferential wall thickening in the proximal right transverse colon with few colonic lymph nodes. Colonoscopy showed a tribal growth in the same location, and the biopsy was adenocarcinoma. So he underwent right hemicolectomy with lymph node dissection, and the histopathology is C3N0. So I will start with Dr. Prasad Narayanan. And Dr. Prasad, what additional assessment you would require to ascertain the course of treatment in this patient?
I think an MSI testing, you have put that in the slide itself. MSI test definitely would be done for this patient. And to the query of IHC versus PCR versus NGS, I think practice has been IHC in most of the cases.
So, sir, Dr. Prasad, what frequency of patients do you find to be MSI positive in your practice?
Hardly, actually. Now this is a T3N0, this is a stage 3 stage 2 colon cancer patient, and I have not seen a MSI high patient in my practices, even though we do for all patients. Maybe Dr. Shekhar Patil sir can take
yes,
this.
Yes. I would like to ask Shekhar sir, because the literature quotes a figure of 15 to 20%, but we hardly come across any patients who are MSI high or DMMR. So, sir, what is have you seen in your practice, sir? Shekhar sir is there?
Hello, can you hear me?
Yeah. Yes, sir, we can hear you.
Yeah. I agree.
Sir, your voice is breaking, sir.
The MSI high, where we got with a stacking of whether to what treatment to be given, whether oxaliplatin to be added or 5FU to be given or not. All those issues came in those situations. But generally, compared to the Western literature, I think we don't see much. But still, we continue to do it. Even one odd case, if you find what to be done, we want to know it. That is the basic thing.
So, Dr. Gautam, what additional points would you look in the histopathology report to find out whether this patient requires treatment or not?
Ma'am, I usually look at the points like it is a well differentiated, poorly differentiated, or moderately differentiated disease biology. LVI, PNI, lymph node status, of course. The lymph node dissection, if there are less than 12 lymph nodes are dissected, then it is a very valid point to give adjuvant therapy if he or she is not MSI high. And apart from other factors, like day one presentation, patient was presented with obstruction or perforation or not. These are the points which I usually see in my patient.
Right. So, as Dr. Gautam just mentioned, so various associations like ASCO, NCCN, and ESMO has given guidelines on what they consider to be high risk in stage 2. And what is the recent literature is from ASMO in 2020, where they have divided into major and minor criteria. And the major criteria includes perforation, T4, and inadequately sampled lymph nodes, which is less than 12, whereas all the other factors which Dr. Gautam mentioned include and a high preoperative level of serum CEA are considered minor factors. So, Dr. Preetham, my next question is to you. So, suppose this patient would have been a T4N0. So, the disease is going outside the visceral peritoneum, and the patient is MSI high. or deficient MMR status, what would be your recommendation of treatment in that patient?
So, because the patient is T4N0 and is MSI high, I would definitely consider a combination of capecitabine and oxaliplatin in this patient, because those patients who are MSI high may not have a high role with the capecitabine. So, I would be adding oxaliplatinum to these patients for the stage for T4N0.
So as he rightly mentioned that T3N0, we can still go ahead with capecitabine alone if the patient is proficient MMR or MSI low, but there is a role of oxaliplatin in the MSI high patient, MSI low patients, or MSI high patients or DMMR state patients, and not only MOSAIC trial showed a 7% increase in DFS in stage 2 high risk patients with the addition of oxaliplatin, but also there was a French study which was a retrospective analysis of about 450 patients who were MSI high and received adjuvant chemotherapy in colon cancer. And the first graph is the graph of all the patients combined, and the second graph is the graph of the patients who had stage 2 disease, and there was a trend to increase DFS. So MSI high or deficient MMR status is one category where we can consider addition of oxaliplatin. Shekhar sir, do you do any other biomarkers apart from MSI or deficient MMR status in early colon cancer?
Generally, for stage 2, generally MSI alone we do it, but as a routine we do for all our patients, even in early stage also KRAS, NRAS, BRAF we do it. The application of that one we don't know, but definitely we do for all our patients the initial workup as just to prognosticate it if they are BRAF mutated or anything. They may be slightly more aggressive, and if they are MSI high along with the BRAF mutation, about the further genetic counseling and other things, it may help us. That is the one area we look into it.
So, sir, apart from genetic counseling, if the patient is, say, MSI high but BRAF mutated, would you consider giving him oxaliplatin-based regimen, even if the patient is, say, T3N0, considering that because of BRAF mutation, it is likely to be poor prognostic?
As of today, I don't use that as a marker for deciding on the treatment as such. That's only we don't do it routinely. If at all I do it, it is utilized in a different angle.
So as Shekhar sir said, though the loss of CDX2 and BRAF mutation have shown to be poor prognostic marker even in early stage colon cancer, presently there is no data to say that we should change therapy based on these results. In that the updated survival, they found that in the patient with BRAF mutation, this was a combined analysis of both stage 2 and stage 3, but the patients with BRAF mutation, even if they are DMMR, have a increased DFS and OS if given FOLFOX. Dr. Prasad, have you ever used a nomogram or a gene expression assay in early stage colon cancer, like we use in breast?
No, in one line I have not used. But can I just take your discussion point to Viraj, because Viraj had typed something about the same point which we were discussing. So Viraj says that his, data has got around 20% of MSI high, is what I believe from what he typed in stage 2. Is that true, Viraj?
Yes, sir. In fact, I find myself so unfortunate. Whenever Dr. Kothari operates T3N0, I just flip the page, piche dekh pehle, MSI high hai ki nahi hai? And it is almost always MSI high. I said, anyways, he just gets my blessing.
So what? So you just leave them alone, is it?
Yeah, T3N0, MSI high, there is no role for us, right?
Okay. And if it is stage 3, you said 10 to 15%. So
about yes, 8 to 10% of even stage 3 we are finding MSI high, but we do give them K-pox actually.
And what do you do to test? I'm sorry, I'm taking up Nidhi's moderation.
No. This is all meant for
It was an
discussion.
important point because I have not seen much. I was always thinking this was a theoretical discussion about MSI high in stage 2, low risk patient, but I mean high risk patient. But this is interesting. The 20% data was 20% positive. And what test do you do for MSI?
IHC, sir. Like
only IHC, not any advanced newer test or
we don't even order in our institute. The moment there is a surgical specimen, definitely everybody goes for MMR testing. And Dr. Kothari operates almost around 80 to 100 per year. And I think so. This is I would remember 15-20 patients every year. I get MSI.
Okay. Fine.
Actually, Dr. Viraj, it is a like for us, I don't know. Even I and even Shekhar sir said the same thing. We hardly get any MSI high, and we also do IHC. So,
because we can't give them chemo, right?
right. And it's so you and your patients are lucky, I would say. So, so coming to the nomogram, so while I was doing a literature search on this topic, I found that MSKCC has a nomogram including age, CEA, the lymph node positivity, tumor location, differentiation, LVI and PNI, and they have recently updated their analysis by including patients who were diagnosed till 2014, and they have a very high predictive probability of 5-year freedom from recurrence. Similarly, we have data of all coloprint, oncotype DX, cancerous A, and in fact, that was also studied as a part of NSA-BP C07 trial. But all of these, as Dr. Shaina mentioned, are prognostic and not predictive of benefit from chemotherapy. One interesting thing I found was a study from Canada, which was only in stage 2 colorectal patients, and they used a 30 gene signature to identify high, intermediate, and low risk. And they're high, as you can see in the second graph, their high risk patient really benefited from the use of chemotherapy. But this did not include the MSI status. So coming to the second case, I have a 65-year-old male patient who has comorbidities of diabetes and hypertension. He underwent a right hemicolectomy with lymph node dissection for a colonic mass, and the histopathology was T3N1. Dr. Gautam, what will be the adjuvant therapy that you will use in this case?
It is a low risk stage 3 disease, ma'am.
Yes, it is a low risk stage 3 disease.
So I would be using a 3-month K-pox therapy for this particular patient. Of course, neuropathy will be a concern for me and for the patient. But yes, definitely I would like to give him benefit of adjuvant 3 months of K-pox.
Dr. Preetham, would you prefer choosing Folfox over K-pox, or you would also go in for K-pox in this patient?
Time and again we know that in the trials K-pox and Folfox, when they have compared, there has not been a major difference in the early colonic trials. So definitely for a low risk stage, T3N1 disease, I would definitely err for doing 3 months of K-pox.
Shekhar sir, in how many percentage of patients are you able to give the full dose of capecitabine and K-pox regimen, sir? Like 1000 mg per meter square BD.
It is very difficult. Generally, we start with some 750 to 800 milligram per meter square and escalate in the next cycle. Because majority of our patients get into some or other problems, so we will not be able to continue the treatment. That is our experience from the beginning only. So we start with slightly lower and then escalate with the second cycle to the full dose, whatever is required. But most of the patients don't tolerate the full dose, what is recommended in the Western literature.
Yes. So my question to you, Dr. Prasad, is: do you think that the data which is showing that Kpox is equivalent to Folfox uh, is applicable in Indian scenario where most of the patients are not able to take the full doses of capecitabine?
So 6 cycles of K. I mean, if it is 6 months of therapy, which we have planned, definitely I will go for Folfox because much more comfortable and apart from the neuropathy, which we can monitor and maybe decide or de-escalate later, most of the patients can take up at least 90% of the planned treatment. But with Kpox, as Shekhar sir said, it just goes down by cycle, one tablet goes down actually. By the end of 6 cycles or so, they are hardly taking any capecitabine. But, I think there are this, and if we are discussing on this particular patient, there is data to say that we can maybe give 3 months of treatment for this patient based on the present situation. So 3 months can consider giving Kpox, but given a choice, I would not prefer to give Kpox as an adjuvant therapy actually, because Folfox is pretty easy and much easier for the patient to take.
Dr. Gautam, during COVID, did your practice change of using Kpox versus Folfox? Considering that at least in my hospital for ward admission for Folfox, COVID RT-PCR would be required every time.
Yes, ma'am. For particularly low risk disease, not in the high risk disease, when the N2 node was there or T4 disease were there, T3N1 cases, yes, I have done this kind of preference to my patient. Like Kpox is a very comfortable therapy for the patient and for the hospital as well. But one point is that the capecitabine dose should not be compromised at any cost.
Yes, yes. But eventually we all end up doing that. Dr. Preetham, what percentage of your patients are able to go home on infusion pumps on Folfox, or do you do it in ward only?
See, I practice in Mumbai, so commutation is very problem. They are coming from, see, they will for a 10-kilometer distance, they may have to use 2 hours of journey to come back to the hospital if there is a complication. So generally, we try to keep it in the ward initially 1 or 2 cycles, and maybe later on we shift them to the infusion pump therapy, and quite a bit few patients can take it very nicely.
And my next question is like, if you're using Folfox, what do you do? What do you choose? 4, 6, or 7?
Modify Folfox 6. I choose. Yeah.
So I believe most of us use Folfox 6, but has anybody started using Folfox 7 in adjuvant therapy?
No, I don't have started using.
Because in metastatic setting, most of I have started using Folfox 7, but in adjuvant I'm still using Folfox 6. Um, so um, so these are the points which I just discussed: the ability to give full doses. If the patient, he is ready to get a central line inserted, use of infusion pump, and most importantly, duration of treatment. This we all just discussed that. The Kpox was associated with an improved disease-free survival with a similar overall survival, but with greater toxicity. So, if the same patient has a tumor deposit distant from the primary lesion, would your treatment modality change from 3 months of Kpox, Dr. Gautam?
Sorry, ma'am, I didn't get the question.
So the same
Can you
patient,
repeat it?
T3N1, initially the patient had low risk and we had decided that we will give Kpox for 3 months. Now the same patient was on the histopathology. There was also a tumor deposit which was distant from the primary lesion. Would you still consider giving 3 months of Kpox, or you will change your adjuvant therapy?
I would be going with Folfox in this particular patient because it is more reliable. I would explain this to patients, and if the patient is convinced about the Folfox regimen, then I would be choosing Folfox in this particular patient.
So, so this was a post hoc analysis of the IDEA trial, which was recommended the duration of treatment in colon, and it was found that the patient who had tumor deposit distant from their primary lesion had a worse prognosis, uh, irrespective of the T and the end stage, and therefore, as Dr. Gautam just mentioned, I would prefer to use a 6 months of therapy over a 3 months of therapy in such patients. Thank you very much. If we can take if there are any questions in the chat box.
I think there were two things to be discussed from the chat box. One was Viraj's question that he's asking that he has stopped using bolus 5FU and Leucovorin. So,
Okay.
what is the panel's opinion about that? So we can maybe take that.
Yes.
So maybe Shekhar sir can say, because he has maximum experience of among all of us in this. So you give Leucovorin and bolus 5FU, or you are going for the infusion directly?
Yeah, we are still continue to use that bolus for the first day, Oxaliplatin, bolus, Leucovorin, and 5FU, and then put it in the remaining dose into the pump and send them. That is what we are practicing as of now. In some of the metastatic disease, we are avoiding it, as she told, using Folfox 7. But still not in the adjuvant setting, we are continuing to use the same Folfox what we are practicing. That is a bolus, Leucovorin, and 5FU.
So my question was, if you are omitting bolus sir in metastatic disease, would you also omit Leucovorin then, or would you always give Leucovorin and then infusion?
Regarding the use of Leucovorin, you're talking.
Yeah. Sir, his question is, if you are omitting the bolus 5FU, will you again give the Leucovorin, or you will omit the Leucovorin also?
Leucovorin only modulates the bolus.
Yeah.
Doesn't modulate.
We will omit Leucovorin also.
Right.
Yeah. We'll be. Hello.
Yes, sir. We can.
I am not catching the question.
So they are asking that in the metastatic setting, where when we you said that you omit the bolus 5FU, do you also omit the bolus Leucovorin? The Leucovorin.
I think sir's network is
Leucovorin. I am not. Hello.
We got the answer, sir. He said he omits Leucovorin if he is not using bolus.
Right.
So, sir, you also do that, or you still give Leucovorin?
I give Leucovorin here for whatever.
Whatever it is, right. Whatever it can modulate.
So, Dr. Viraj, like you are using without bolus 5FU in adjuvant also. There also you are omitting Leucovorin?
Yes.
Okay.
But then we up the dose of infusion 5FU to 3 per meter square. Right? Like in Folfox 7.
Okay.
High doses. All right. I think so. Thanks for the wonderful panel, Dr. Nidhi. It was a great discussion. And thank you all the panelists.